Morning.
There you
Hi,
are.
good morning. Good morning, Jose. This is Mohamed Masoud. Thank you for inviting me to this webinar series. I'm an orthodontist practicing in the DC area, Northern Virginia, Falls Church. I was in full-time academics for a long time. I was clinic director at BU for a couple of years. I was program director at Harvard for about 8 years, and I still teach part-time at both Howard here in DC and at Harvard. And during the pandemic, I moved to the DC area, and I'm practicing at Berman and Masoud Orthodontics. Today, I'm going to be going over a case with you that involves upper lateral incisor extrusion, and it involves some molar distalization, both of which are challenging movements with clear aligners. We were exclusively Invisalign for a long time, and we transitioned to in-house design and mostly in-house production of aligners a couple of years ago, and it's been a very nice experience. And I'll share with you some of the things that we experienced in the process. So let me share my screen. And I'll go over the setup with you. Okay. Can you see my screen?
Yes, go ahead. Your screen is clear with the Titan interface already.
Excellent. So this is our case. You see the molars on the left side are about a half, molars and premolars are about a half cusp class 2. Usually for me, if I'm going to distalize, I try to distalize around a half a cusp or less. If it's more than a half a cusp, especially if it's a growing child, I'm looking at other options like using the twin block feature, or if it's an adult, upper premolar extractions or surgery or whatnot. Half a cusp is what I think is pretty predictable and easy to easy to distalize. I'm not going to say I never go above a half a cusp, but half a cusp is what I'm generally comfortable distalizing. It's fairly predictable. So on this left side, the canine might be a hair more than a half a cusp. The premolars are about a half a cusp. You have a class 2 division 2 type of anterior pattern, but usually class 2 division 2s are deep. This patient has an open bite, which is a little bit unusual. The left side's the right side, sorry, is a little bit less class 2, maybe just a quarter cusp class 2 on this side, on the premolars, and the canines just short of a half cusp class 2. And with open bites, you'll tend to see this pattern of the class 2 getting worse as you go forward. And most open bites, you'll see that pattern where on the molars, maybe it's a quarter cusp, with the premolars, it's a half cusp, but the canines, it's about 3/4 of a cusp, or maybe a little bit more than a half cusp. So this is a case that I think is challenging, because if in your typical class 2 division 2 pattern, you can open the bite by intruding the upper centrals. In this case, you don't particularly want to intrude the upper centrals because the patient has an open bite, and you want to extrude the incisors more than extrude the upper laterals more than intrude the upper centrals. I also want to make sure that during treatment, I'm intruding the molars a little bit, because the patient is contacting in the posterior before the anterior. And my strategy for this case is going to involve a little bit of intrusion and distalization of the molars to try to get some auto-rotation of the mandible, some proclination of the upper incisors so that there's room for the auto-rotation to happen, and some extrusion and retroclination of the upper laterals. That's kind of my strategy. Whether I'm going to do it with braces or aligners, that's going to be my main strategy, is to try to intrude and distalize the upper molars a bit, procline the upper incisors a little bit, upper centrals a little bit, and get extrusion and retroclination of the upper lateral incisors. So this is the scanned model. I'm going to go through the steps here. The forward and backwards at the top left corner takes you through the steps of the process. So I'm going to go to the next steps, orientation. What comes from the scanner is usually okay, but if you need to modify it, you can modify it here. You rarely need to do that. This is the auto. In the old days, we'd have to put clicks on every tooth. Now it automatically does it, and it does it fairly well. That's the maxilla. Again, I'm going to go through the steps at the top there. Do you see my my mouse on your screen?
Yes.
Okay,
Yeah,
good.
yes.
All right, perfect. So just make sure the green dots are all in the right spots in the middle of the tooth. If something's missed, or you can obviously adjust it or change it. So I could take the dot and change it to a slightly different position, or if there's a missing dot, I can do it manually. The next step is segmentation. And this is the auto segmentation that you need to check. It usually does a really good job, but sometimes there are errors in the AI segmentation. So I mean, this is pretty minor, but you know, I'll go there and just adjust the border of the tooth a little bit. If you click the tooth and go out, it extends the limit of the tooth. If you take the gums and draw around the tooth, you can trim any extra. And like over there between the premolar and canine, you could make the paintbrush a little bit smaller, and you can kind of fine tune that a little bit. But in general, I think it did a pretty good job with the segmentation here. That looks good. I'm looking at the lower. So again, you want to check it. Once in a while, there'll be a mistake, or you know, it'll miss out. Let me just make this bigger. It'll sometimes leave out a cusp. It'll look kind of like this, especially in the upper, sometimes upper molars, and you'll need to adjust it. So you just click the tooth and then paint to adjust that. It doesn't happen very often, but you do need to check it because you don't want the border of the tooth to be inaccurate. Okay, so the area that is sometimes happens, where it sometimes happens, is the distopalatal cusp of the upper second molars. Just double check that and make sure that the border of the tooth includes that area. Okay, next step is identifying the teeth, and you've got the tooth numbering, so the Palmer tooth numbering system working okay here. If there's a missing premolar, you can go in here and just change the number of the tooth, and it'll automatically change the numbers behind that. So let's say if this case we're missing a premolar, you can change that 4 to a 5, and it changes 5, 6, 7, 8 instead of 4, 5, 6. I'll take it back to what it was. All right, next step, we'd go looking at the mandible. Again, just double checking that the numbering system's okay. Next comes the root and long axis of the tooth. So this is
sorry,
yes.
Mohamed. Sorry, go back to the upper arch. Sorry to correct this because you put 8 in place of 7 in the upper arch.
I didn't. Yeah, I didn't. Okay, sorry.
Yeah, no, it's okay.
Thank you. Yeah, thanks.
Yeah, I know.
Thanks.
There you are.
So it's 7, 6, 5, 4. We're good. Yeah, sorry, I messed with it. Okay, and so 7, 7. So just again, double check the tooth numbers, make sure they look good, and go to the next step. The next step is marking the long axis of the tooth and the axes of the teeth. This is important. So when you're moving the teeth, when you put a click mesial, it actually moves it mesial. If this looks like this, if the axis is incorrect, when you click a mesial click, it's not going to take it truly mesial. It's going to take it, mesio-buccal kind of thing of the tooth. So it's important to just check. Again, the AI does a reasonable job, but again, this is something that you need to check and make sure that the axis is correct. If that second molar is a little bit more rotated. And it usually does a good job with it, but you just want to double check that. And then you want to double check the roots, make sure the root axis is correct. For example, here, that tooth is a little bit more tipped. I can correct that. Okay. All right. At this point, I like looking at the tooth measurements because I want to know if there's a tooth size discrepancy. And the Bolton tool is really nice. You've got the 3-3 Bolton and the 6-6 Bolton. And this tells me there's a maxillary excess. So I want to make sure I don't do too much IPR in the lower. And if I do some in the lower, I may also need to do some in the upper since the tooth size discrepancy is already on the larger side for the upper compared to the lower. All right, so I'm going to my setup here. I'll usually start with the lower. I'll look at the lower arch form if I'm happy with it or if I want to change it. Usually I'll stick with the original arch form and I'll decide on the perimeter that I want to use. So for here, especially with the recession that this patient has, she does have some recession. So if you want to look at the colors initial, you can click over here and you can look at the original color. You can see that there's some recession there. So I don't really want to procline. I want, if anything, to more or less maintain the initial perimeter of the patient. So I'm going to start aligning them. I generally do it manually. Titan does have some really good text that can help with this, but for the purpose of this webinar, and I'll just do a quick one, and then we can go to the actual setup that was done for the patient. This patient was actually just scanned for a refinement scan. So I'll show you the actual outcome that this patient had. So that central incisor is a little bit tipped lingually, so I don't mind moving that one a little bit buccal. But I don't really want to move the ones that started out labial, more labial. So we will need to do some IPR. But I'm just starting out with where I want the teeth to go and where I want them to end up. And it's going to afford a little bit more procline. And the red boxes show interferences. I don't mind expanding the canine just a teeny bit, not too much. And then I'll adjust the IPR here. And you can modify it later, but to start with, sorry. The 0.4 IPR is an amount that I would usually do with an IPR burr, like a mosquito IPR burr. So I'm adjusting the amount of IPR. A negative means I'm creating more collision. Okay, and then that yellow box shows areas where there's an interference beyond the amount of IPR that I want to do. And you can either auto stage to get rid of it, or you can just create a key to get rid of it. For now, I'm just gonna set the lower teeth to approximately where I want them to be. I'll deal with the collisions a little bit later. But this is just a rough draft of where I want those bottom teeth to end up and how much IPR I want to do. And any collisions I don't want, I can just X out of them. All right, in the upper, I want to distalize the molars, distalize and derotate the molars, as well as intrude them to get a little bit of mandibular autorotation. And I'm looking over here to see how much distalization I'm going to need to do. And they look like they can afford to be tipped back a little bit as well. and I want to intrude them. So this is one of those cases where, so in most cases, I want to finish with heavy posterior contact and no contact on the anterior in general, because most cases start either with either normal or on the deeper side. Since this patient has a bit of an open bite and I want to get a little bit of auto rotation, I'm going to plan on finishing this case with little or no contact at the molars. And again, as I said, I'm intruding and distalizing because distalizing can open the bite a little bit. So in this particular case where she has an open bite tendency, I want to intrude and pair it with some distalization. So you see over here, I have about a 0.5 millimeter of distalization, and I have about a 0.5 millimeter of intrusion, sorry. So over here, you've got the numbers of the actual movements that were done. And if I just want to close that space, we can just go over here and just click an X, and that kind of gets rid of that space. Now, the upper centrals, if you remember, we talked about wanting to procline them a little bit because I don't want the patient to bump into the upper incisors when I'm intruding and distalizing the molars. Aligners are pretty good at moving the molars a little bit away from each other and intruding the molars a tiny bit, and that would create an anterior interference in this case if I don't procline the upper incisor, move the upper central incisors out of the way so that the patient has room to auto-rotate. I want to get some of the closure of the anterior open bite by auto-rotation, and that also is going to help me with my class 2 correction as well. So I'm going to take the upper centrals and procline them. I need to distalize the upper molars a little bit and derotate them a little bit more. Upper second molars are flared a little bit buccal, so I'm gonna torque them a little bit. Root buccal, they're flared buccally, so I'm gonna tip the roots buccal, crown lingual. Maybe I derotated that a little too much. Okay, and I'm going to look at this side. And this side, as I said, doesn't need as much distalization. Maybe just a little bit of distalization paired with some intrusion. And again, about a 0.5 millimeter of intrusion will give you quite a bit of closure in the front. I was checking the buccal overjet to make sure I didn't tip it in or that it's still compatible with the width of the lower. Okay, so I'm going to take these premolars and derotate them. This one needs to flare a little bit buccally. And then I'll just X out of these spaces just so it can automatically close those gaps for me. And that canine's pretty rotated. Any initial discrepancies, I'm going to try to over-treat them. So if like these two contacts, the mesial and distal contacts of that lateral are too buccal, I'm going to want to make sure that they finish a little bit towards the palatal or the lingual. So here I'm not going to use these arrows because I want them to tip lingually a little bit. You can see that lingual surface of those upper laterals, they look like they're flared labially. So I do want them to tip lingually. So I'm going to use this tool over here and not the buccolingual tool over here. So I'm going to tip that lateral lingually. And don't worry about the collisions now. We're going to deal with them, and those interferences, we'll deal with them later. I'm starting out by putting the teeth where I want them to end up. That tooth is a little rotated. And it still needs a little bit more torque, so I'm going to take the root. And so this moves the crown buccal and lingual, and this moves the root buccal and lingual, the second one from the bottom. The upper left lateral looks like it was more flared than the right one, so I'm just moving the root a little bit buccal so that they look a little bit more similar to each other when I'm looking at them from the occlusal. And I don't particularly want to do a ton of IPR in the upper, sorry. So let's work a little bit on the rotation there. And then over here, I'm going to extrude those teeth. So again, when you pair extrusion with retroclination, it tends to track a lot better. Extrusion is a very challenging movement with aligners. And when you pair, if you notice, like we did retroclination of those teeth, we have about 6 or 7 degrees of retroclination of those teeth. And when you pair the extrusion with, and retroclination is a pretty predictable movement with aligners. When you pair the retroclination with extrusion, which is not a very predictable movement, it tends to track a lot better. So any chance I can pair, if I have a challenging movement, anytime I can pair it with a more predictable movement, that's always a good thing. You get better tracking in general. I'm going to work a little bit on the tip of that tooth. And I'm going to want to finish with a bit of clearance to allow for the auto rotation to happen. And I'll show you what actually happened in real life, because this is a case that we just scanned for a refinement. So I can show you what actually happened after we did this type of treatment for the patient. Again, I'm trying to get the majority of this, at least some of the space from distalization of the molars and some of it from proclination of the upper centrals. That's how we're resolving the upper anterior crowding. So I'm going to get rid of these spaces here. That still needs a little bit more retroclination. Again, I'm going to try to have that retrocline a little bit less than the one on the left side. And I'm going to get it so that it ends up, if anything, a hair over-treated to the lingual into the buccal, because it started out a little bit buccal. So a little bit of over-treatment's always good. Okay, and we've got some derotation of the molars to do over here. Checking again when I'm moving premolars out or in, I'm looking at the buccal overjet to make sure that the clearance makes sense. So in this case, I need to tip those molars in a little bit. Again, that's why I like doing even a rough draft of the lower in the beginning, because that's my template for setting the upper. See, I'm needing to distalize just a little bit more there. Okay, that's a little too buckle. I won't waste too much of your time with this. I'll just get it close and then I'll show you the actual setup that was done for the patient. So what we planned, we haven't done any staging so far. I like doing the staging at the end. But I'll start out by taking the teeth to where I want them to end up, and then I'll add the staging. For me, that's kind of how I'll usually do it. I know some people will stage as they go. So I'm going to get rid of I'm going to try to do this with no IPR in the upper. So I'm just getting rid of all the interferences here. Now we still have these boxes of mid-course collisions. And the way we're going to get rid of that is by creating some staging. But before I do it, let me just kind of adjust the tips on those lower incisors. And this one's probably going to need an attachment since that's a significant amount of tip on that tooth. And when I'm adjusting the tip or the extra or the leveling, you tend to get a little bit of change to the alignment. So you want to go back and just check the alignment one more time. That one needs some tip. And this is fairly rough and quick, so to kind of show you how the process works. That lower right central started out buccal, so I'm going to make sure it ends up with a little bit of over treatment. I'm going to over treat all the contacts that started out a little discrepant. And don't be shy with the over treatment. It's okay to have like a quarter or half a millimeter of over treatment. It doesn't usually, once in a while it'll play out, but it doesn't usually play out. In real life, you're lucky if it looks okay, if it's where you want it to be, even with like a half a millimeter, a quarter millimeter of over treatment. So again, I'm adjusting the IPR here to where I wanted it to be. I'm planning on doing about 0.4 millimeters of IPR. That root needs to go a little buccal. So again, I'm over treating that central incisor, so it ends up a little bit more labial than where I want it to be. And also the mesial, those fours, I'm going to over treat them a little bit since they started out buccal. I'm going to end up with them a little bit lingual. And again, I'll get rid of those interferences. So I'll show you the staging and getting rid of the interferences. So let's go to the upper. So in this case, I want to eliminate those 0.4 and 0.6 interferences. So what I'm going to do is I'm going to go to stage 4 or 5. Depends on how many stages I think I need to eliminate that interference. So in this case, I think it's going to take me about 5 or 6 stages. I'm estimating, and I can change it. I'm going to estimate that I need about 6 stages to eliminate these interferences. And the way I'm going to eliminate the interferences is by staging and getting the molars to distalize, in advance to make room for that space to be resolved. So I'm going to go here, and I'm going to go to the plus sign at stage 6, and that's going to create a keyframe. I'm going to click apply, and that creates a keyframe at that point. And what I'm going to do here is I'm going to distalize the molars here at this point. And what that's doing is it's getting the molars to distalize in advance. And it's giving me, so I'm creating a waypoint or a position, intermediate position that I want the teeth to be at. So what I'm doing is I'm distalizing, I'm creating the space where I want it to be so that that lateral can comfortably move in. And usually with the distalization, I like to keep a little bit of space between them in this intermediary stage. So you see there, we eliminated the interference there by having more of the distalization occur earlier and less of it. So what I did is that I accelerated, instead of the distalization of the molars happening throughout all the stages, it's getting concentrated in the beginning so that we get the space where we want it a little bit earlier. And you can eliminate the interferences as well by expanding. And we also wanted some proclination there of the incisors. So that's also going to help us with that. Now, the other way to do this is to go to the tools. Is to just click on the screen here and go to auto staging. And that will eliminate all the interferences automatically. Now, sometimes I'll do that and I'll see if it increases the number of stages too much. So if I go to click mid-treatment collisions, it increased it to 20 stages to fix the mid-treatment collisions. I think I can do that in a little bit less. So that's why I'm just creating an intermediary step. And I think if I do it myself, I think I can get it to around 17 or 18 stages. And that's kind of what we did, what we ended up doing in this case. This case ended up with 17 stages. But you can see here, I'm kind of concentrating the movements that help us eliminate interferences. I'm concentrating those movements earlier so that before the laterals complete their movement, they've got a little bit more space. And I'm using that distalization space and the proclination of the upper incisors, focusing that so that most of it happens before stage 6, so that we eliminate those interferences. The other thing you can do is also delay the movement of the lateral incisor so it doesn't start till later. So you can go here. Again, you have to be in the unlocked mode for you to do this. And then here I can change the movements from all the teeth moving to the timelines changing together to individual tooth. And the other way to do this is to say, okay, that upper right lateral it has a big interference there. I can take it and have it start its movement a little bit later. And what that does is it doesn't start the movement to later, so that there's a little bit more space. I'm not going to do that in this case, so I'll just take it back to the way it was. But you can see there we're in the process of eliminating those interferences by moving the teeth more distally and expanding a little bit earlier on at that intermediary stage. You can see there we've eliminated that interference there. And I'm doing something similar on the other side as well. So I'm gonna just go straight to the actual setup that we did for this patient, just so we don't spend too much time on this. So you can always go to an old setup, even if you've changed everything and you don't like it, you want to go to a setup that you worked on before, you can always go to an old setup. So this patient was approved in April 2024. So I'm going to go back to that setup. I'm going to revert to that. So as you can see here, it's 17 stages. And we actually didn't do that much IPR on this patient. It was just 0.2 millimeters of IPR. Again, because the tooth size discrepancy wasn't that big. You can see a lot of the staging here involves, distalization and proclination of the upper centrals. And you see those laterals, they even kind of wait. They don't start movement until a little bit later. So they kind of pause a little bit. If you look at those upper laterals, they're pausing until the uppers are out and the molars are distalized, and then they start tipping inward, retroclining a little bit later in treatment. So it's 17 stages. I'll go through the attachments we use. So you can see here I have big attachments oriented, and this is nice that it orients it with the force. But in this case, I'm not sure why it's doing that. In this case, the attachments were oriented horizontally to make sure that we get a push surface for the aligners to extrude them, to extrude the laterals. Again, intruding the molars doesn't usually need, I probably should have put an attachment on one of those molars for the aligners to grip a little bit better and to make sure we got that distalization to track better. You'll see here I have a button cut out on the canines, but a slit for a rubber band on the molars. Again, this case is starting out with an anterior open bite. So I don't want to get any molar extrusion, which is why I don't have a button cut out on the molars. If it was a case where I wanted to open the bite and I didn't mind extruding the molars, I'd have a button cut out on the molars. In this particular case, two things made me put button cutouts on those upper canines. First of all, the upper canines are rotated mesial. So when I'm using a rubber band to the canine, the side effect of the rubber band is going to be to extrude and to rotate the canine distally. In this case, those are side effects that I want. They actually help me. The patient has no contact on the canines. I don't mind the canines extruding a little bit. I also want the aligners to track better here. So I don't want to be pulling on the actual aligner so it pulls away from the teeth. So in this particular case, I have a button cut out on the canine because I want the canine to extrude. I want it to rotate distally, which is going to happen with a class 2 elastic. And I want it to extrude, and I don't want the aligner to lift away from the teeth. Now, if you can plan this distalization on the computer, but the teeth don't watch the cartoon. So you have to use a rubber band to make that molar distalization occur. And the aligners, again, are pretty good at intruding the molars. So let me show you what actually happened with this patient. So this was the setup. It was 17 stages. Just for the heck of it, I sent this patient the setup to Invisalign. And you'll see here that they give you and I asked for distalization, but they didn't actually give me the distalization. But despite that, you'll see, let me just kind of go here. They give you 30 stages, and I was easily able to get it to happen in 15 stages. So let's go to the setup. I'm trying to go back to the setup that they gave before. It's not letting me, but it gave me well over 30 stages. Sometimes you can go in and look at it. Since it's modifying it, because they didn't really distalize the way I asked them to distalize. So I'm assuming the number of stages is going to increase even more. But so let me show you what actually happened on this case. I'm going to click yes, because I kind of reverted back to what we had initially had of 17 stages. Okay, that's good. So this patient then had a refinement scan that just happened a few weeks ago. So she started out with 17 stages, and I'll show you what she looked like on that scan. You know what, let me go back. Okay, so I'll show you what the patient actually looks like on the refinement scan. So The upper laterals tracked beautifully. They're almost the same level as the centrals. The overbite is better. It's not fully corrected yet. The class 2 relationship is better. It's not fully corrected yet. The intrusion of the molars tracked okay. She's contacting early on the premolars, which now we need to eliminate. So now we have an interference at the premolars that we're going to need to eliminate so that she can close down a little bit more. But she's close to class 1. She started out with the canine a little bit more than half class 2. And at this point, we're close to class 1. But just 17 stages into treatment, it's a good place to be at this point. And I'll show you the setup that we did for her here. Okay, so it was 6 aligners. I usually record spaces. So when I'm doing a refinement, I'll scan and then I'll use floss and gauges to measure any leftover spaces. So these aren't really IPR. These are spaces that I recorded. You can now put them into the setup. So when you're in the root stage, you can go and tell it that there's a space here. But at this point, when I did this, I just planned virtual IPR that I'm not going to do in real life to get those contacts to be a little bit tighter in the areas that I recorded it. So this would be like the upper right 5, 6 had a space. Upper left 5, 6 had 0.4 millimeters of space. And so lower right 3, 4. So I'm not planning on doing any IPR there. Those are just areas where the contact was a little bit tight and a little bit loose, and I wanted to tighten it. So if you see over here, that lower right lateral tracked okay, but even though we built over treatment in it, it's still a little bit behind. So I made sure I over treated it a little bit more in these 6 stages. And this was made on direct print aligners. The initial setup was made with traditional vacuum form polyethylene aligners. We just in the office transitioned to direct printing of aligners, and those work best in batches of 12 or 6. So that's why I try to keep it to multiples of 6, just because the print plate does 12 at a time. So I just from a and for an appointment scheduling point of view and from a work efficiency point of view, I try to keep the aligners to multiples of 6. See those laterals retroclined nicely, the upper centrals proclined nicely, and here it's just a little bit of over treatment. Let me just switch to edit mode here. And to be honest, here, since we have a little bit of collision there, I'm going to take a look at where the collision is and make sure we're eliminating those interferences in the refinement. Now, if the patient was still, and the patient actually still is touching a little bit on the molar, if you look at that green spot, she still has a little bit of contact at the molar. What I'll sometimes do is if there's a stubborn premature contact to the second molars, or if there's a more significant open bite than this, I'll put bite ramps or bite turbos on the molars so that the patient has a prematurity there when they're wearing the aligners to help intrude the molars a little bit. So let's look at the attachments. So in this case, the upper centrals were still a little bit tipped. So I put some attachments on them to help tip the roots to the patient's left. And I'll usually over here write a note to myself with the things that I see clinically that I want to do in the refinement. So in the refinement note, I'll write upper right 1 mesial out, lower right 1 mesial and distal out, level the lower 2s better, close the spaces, eliminate premature contacts at the premolar. So I must have noticed clinically the patient had their first contact at the premolar. I wanted to make sure, it's a note to myself to remind myself to make sure that there's no contact at the premolar so we can get a little bit of more auto rotation. Keeping the class 2 cuts, and upper left 1 mesial up, and both upper 2s need their roots to go distal. So those are notes to myself to make sure I'm addressing those issues in the refinement. And I just added a few attachments there. So yeah, I mean, this patient started in April, and this scan was done in January, and she's in a pretty good spot. Her treatment estimate was 18 months, and I'm anticipating that we're going to finish this case early based on the progress we've got so far. So that's what I wanted to share with you today. It's been a really nice experience transitioning to designing aligners myself. The biggest thing that I noticed was that the number of stages is a lot smaller. So when I'd send it to like a technician with any of the bigger companies, I'd always get a setup back in the 30s or 40s, especially if there's distalization. Sometimes you'll see setups in the 40s and 50s sometimes. But since I've been doing it myself, I can control when the IPR occurs, how the staging happens, and I can reduce the number of stages significantly by having that control. So Jose, if you want to ask me anything about the case, I'm happy to answer any questions that you or anyone else might have.
No, Mo, it's a beautiful case, beautiful way to drive Titan with all the tools and the spaces. So thank you so much, Mohamed. Beautiful, beautiful way to drive it.
So I wanted to ask you, because I know you do a lot of setups, and what do you usually, and this is just the way that I ended up doing it, where I do the setup and then I do the staging later. Do you do it that way, or do you stage
Yeah,
as you go?
the first thing I do all the time is to do a draw, okay, to a draft to check all the movement I need, and then I make the staging as you do it. Okay, it's an easy way to do.
Yeah.
Build the setup already, and then check the spaces and distribute the spaces. Something like you is nice.
Okay.
It's
Yeah,
a right way to do.
I've seen other people that kind of create a key point for where they want the teeth, and then they create the next key point, like the next frame. So they'll create the frame, the opposite of what I did. And I guess there's no right or wrong way to do it, but I guess I've seen some people do that instead.
Yeah, it all depends what you want with the case. For example, if you want to make distalization with stagings, okay, sequential distalization. First, you're doing everything, and then you make the sequence. You do the staging. It's easy way to do.
Yeah. Yeah, I mean, speaking of that, I mean, you just adjust the timeline. Like I was showing, you can just click the button that changes it from full arch to individual teeth, and you can just delay the movement of the anterior teeth so that it occurs after the posterior teeth have already distalized.
Yeah. Do you want to show your screen again to show?
Yeah,
that?
I can show my screen again to show if someone wanted to do that. So I'll just switch to edit mode here. So if you wanted. Oops, sorry, let me go back.
Yeah, we don't. I don't. We don't see your screen still.
Oh, okay.
Mohamed.
Okay, just a sec. Let me. Share screen.
Yep. Yeah, there you are. Perfect.
Okay, I'll just switch to edit mode. So if I wanted to kind of distalize the molars, again, these are aligners we've already made, and I can easily discard these changes. But if I want to, if this case needed more distalization, I can go to the last stage, do the distalization that I want, and then open the stages here and change this from full arch to individual teeth, and have like the 6 start to move after the 7 and the 5 to move after the 6. So you can kind of do something like that, so that every tooth starts to move. So the second molar starts to move first, and then a couple of stages later you can have the 6 start to move. A couple of stages later you can have the 5 start to move, and so on. Or you can move them in batches. Sometimes we'll do 7 and 6, 7 start to move, and then 7 and 6 together, and then premolars move after the molars are already in class 1. You can do that with. So 6 would move after the 7, a couple of stages, and so on. So, and then if you want to even not move the incisors at all until the distalization occurs, you can do that. So it ends up looking. Well, usually you'd start the incisors together, but it'll look something like this if you wanted to move, you know, the second molars, distal, and then the first molars, and then the premolars, and so on. So the setup would kind of look something. You can adjust the so that they all finish and start together, but sorry, that they all finish together, but change the start point so that the molars move first and then the incisors move. I'll do that a lot if I'm distalizing in the lower. So if I've got a class 3 case and I'm distalizing the molars, I'll usually not move the incisors at all and completely pause, because I don't want the incisors to procline when they're already kind of edge to edge or a little bit class 3. I don't want the class 3 to get worse. So I'll usually start the molars moving distal first and then postpone the movement of the incisors after the molars have already distalized. So that's another consideration, especially with lower molar distalization, where you don't want the anterior crossbite getting worse. I don't know if you do a lot of lower molar distalization, Jose, but that's kind of what I'm usually thinking of when I'm doing lower molar distalization.
Yeah, yes, I do it, but yeah. Yeah, and this way to do is beautiful. It's working very well because Titan gives you opportunity to do it really easy.
So I'm just gonna, I don't want to save this. Okay. All right. Let me just stop sharing my screen.
Okay, let me open my camera.
So
Mohamed.
Yeah, so thank you for
ahead.
inviting me. And yeah, I look forward to doing this again sometime.
No, thank you so much. Yeah, the idea is that doing frequently webinars with all the team. So thank you so much, Mohamed. Okay.
Thank you. I'm happy to share another case with you next time. Thank you.
Thank you so much.
All right. Take care. Thanks.